Good afternoon, good morning, and evening, if some of you are joining us from different time zones today. And welcome to the third and last webinar, How Can We Take AMR Advocacy to the Next Level, Including Policymaking? As I told you, this is the third and last webinar of this webinar series, and the objective of this series was to create a space for a diverse group of patients to share stories and connect and engage with other groups about AMR advocacy. I'm Francesca Chiara, and I'm the chair of the AMR Narrative, and I'm joined today by Vanessa Carter, who's the executive director of the AMR Narrative, but also chair of the WHO Taskforce of AMR Survivors, and Elena Balestra, head of governance and membership and capacity building at the European Patient Forum. So the first webinar featured patient groups and patient advocates discussing how to improve advocacy, while the second webinar focused more on various stakeholders and reflected on how to better engage communities on this issue. And now with the third webinar, we are digging deeper down into how to move to the next level, so how to engage the policymakers in conducting effective advocacy. And this is in preparation of the United Nations General Assembly that will discuss AMR later this month. So today we will hear patient stories from two patient survivors, Rob Purdie and John Kariuki. We also have an introduction from Vanessa Carter about the WHO Taskforce of AMR Survival, and then we will conclude with a panel discussion with experts and patients representatives. So I would like to just quickly give you some housekeeping rules. So please mute yourself when not speaking, use your headset and earphones if you have them, and please use the chat box in case of technical issues. And also you can use the Q&A chat if you would like to ask questions, especially during the panel session. So I would like to give you some brief explanation about introduction about the AMR Narrative. So the AMR Narrative is a very young patient organization, which is UK based. It was launched last year with three key aims. The first aim is to make knowledge about AMR accessible, especially to patient groups and to the wider community. The second is to show and highlight patient stories about resistant infections. But most of all is to create advocacy capacity among patient groups so they can conduct effective advocacy when telling about the stories, but they can also bring the issue at the political level. And so I'm gonna pass it to Elena, which will give an introduction about the work of the European Patient Forum. Thank you.
Thank you very much, Francesca. So the European Patient Forum is an independent, not-governmental umbrella. We were founded in 2003, and we currently represent 79 members that are either national coalitions or EU disease-specific organizations, which means that those organizations are either organizations that have a very wide geographical focus, sometimes either EU, Europe, or even international, but with a strong geographical focus on Europe, and on the other hand, they have a very specific disease focus, or national coalitions, which means that our organization have a very specific geographical focus, like a specific country, but they do cover several conditions. So this is who we represent, and you can see here below our vision and our mission. Thank you.
Thank you so much, Elena and Francesca. So as mentioned, I'm currently the Executive Director of the AMR Narrative. And one of the things I'm going to do in my presentation is talk about the task force, the WHO Task Force of AMR Survivors, as we have two very, very respectable patient advocates that are going to share their stories as members of the task force. Next slide, please. So as a brief background, I'm not going to spend too much time on my story. Obviously, storytelling is important. So I had a car accident in Johannesburg in 2004. I had many, many different injuries, including to my face, to my abdominal region, I had a fractured pelvis, neck and back injury. Next slide, please. This is a snapshot of what I went through over 10 years to reconstruct my face, because that was most complicated. Next slide, please. When I had my fourth prosthetic implanted, I was diagnosed with MRSA, or methicillin-resistant Staphylococcus aureus. This was a test results on the right-hand side. Lots of R's, meaning I was resistant to the type of antibiotics they were giving me, and some S's, about 5 S's that meant I was susceptible, meaning those kinds of antibiotics did work. But after a very long journey, for 3 years fighting infections, this is what my face looked like, because the bacterial infection that was resistant to antibiotics had eaten away most of the skin. Next slide, please. So we did a bone reconstruction to try and avoid too many surgeries. And as you can see on the top right-hand side, this is what my face looks like today. When they did this particular surgery called the zygomatic osteotomy, or bone reconstruction in the face. Next slide, please. But the infection returned, and by this time it was the 5th time that I was fighting the resistant infection. And so what happened was the doctors rotated antibiotics, and eventually, next slide, please. This was the result, which I know is not perfect because I do have a facial disfigurement left from it, but I was extremely relieved that the infection had finally cleared, and I was quite fortunate that it didn't turn into anything more serious, such as a bloodstream infection or sepsis. Next slide, please. So this webinar is based on, we as patients, we go through these journeys. In 2013, after I finished my facial reconstruction and fought all those infections, I became a patient advocate. And one of the biggest things for me was because AMR, or antibiotic resistance in my case, was not common knowledge. It frustrated me that it wasn't being communicated clearly enough. So these are kind of photos of the different work that I've done, including working in policymaking and including working in medical education. The purple graphic in the middle is actually a stewardship team at the Charlotte Maxeke Johannesburg Academic Hospital that invited me back to share my patient story, to help the nurses and the doctors working in that stewardship team to understand the importance of how they could be working better, and understanding the human impact of what it felt like as a patient to deal with those recurring infections. Next slide, please. So later on in my journey, I was appointed a chair of the WHO Task Force of AMR Survivors. The top left-hand photo shows the 12 survivors that the membership is made up of. We all have different lived experiences of AMR, and this is really, really important, because AMR is what they call the cornerstone of modern medicine, because it impacts any single disease or condition, including surgical interventions like mine that relies on antibiotics to cure them. So we have members from the USA and Canada. We have members from India, Zimbabwe, Indonesia, the USA, Kenya, Nigeria, Lebanon, and the UK. And basically our task is to go out there, share our stories, to make an impact on policymaking, to really bring the human face to the problem, instead of just talking about numbers and statistics, and the technical framing of what AMR actually is. Next slide. So these are some of the materials that we've created as the Task Force of AMR Survivors. There's a QR code at the bottom if you'd like to scan it to learn more. We have 3 videos at the moment that we'd like to encourage you to share, but also the other assets that we've got, because again, there's 12 members. The hashtag that we use at the moment is hashtag AMR Survivors. Next slide. So this is a really, really important document. And if you're a patient advocate only entering the realm of AMR advocacy for the first time, this is going to be really helpful to you. So if you go onto the website page, and you can see at the bottom left-hand side, it's the website page is listed there. This was put together by the 12 members of the task force. And what we really focus on is different avenues that you can explore. So you don't just have to do policy making. You might want to work in medical education and so on, but your story matters. And so this is really what we've worked on between all of us, to be able to make it, to be able to provide it to technical experts, and again, patients and the public, to show them avenues in terms of how they can be involved. Next slide. So I'm just very briefly going to go through, this is the same document. We've highlighted 10 different areas. So that could range from anywhere from public awareness, sharing your story, working with the media and so on, health worker education. As I said, I've personally worked with quite a few different universities and academics to share my story, to bring to light when medical students are taught about AMR, when they hear the personal perspective of survival, how they can improve their response to AMR. Policymaking, as I said, very, very important, because this is a very technical issue. When we share our stories, it makes it more relatable to policymakers and potentially changes policies. Next slide, please. So national action plans, this is also something that I've been grateful to be involved with. We can be powerful champions to, bring forward what do we go through in the health system. And, it shouldn't just be another a political gesture to put in place a national action plan. We need to be listening to people on the ground to design these national action plans. Otherwise, they will not be patient and people-centered. And so again, this is something that we could seek out as patients, to work with our local governments to say, well, why is there not a task force? Why is your ministerial advisory committee not involving patients or even patient organizations in developing these national action plans? So I thought I'd bring that to light. Your story does matter. Publications, I've been involved in 11 publications so far. I've co-authored some of them. I do not have a scientific background, but what I have relied on is mentorship from the researchers and the academics and other patients as well, for me to be able to contribute my views towards these publications that are really, really important, again, and also inform policymaking. Medical conferences, we share our stories, again, for people and for healthcare professionals that don't always understand what the human impact is. Public health innovation, if we start to talk about artificial intelligence or, the way that we share data, AMR surveillance and so on. I'll speak for myself. I've moved from South Africa to the UK recently. My medical record is still in South Africa. It's not in the UK. I often have to volunteer that information. Medical records need to be following us across borders. And of course, research and development is really important in terms of diagnostics and new novel therapies and so on. So this is my last slide. And I think that in terms of saying that, now I would like to introduce 2 of our task force members. We can go to the next slide, please. Yeah, thank you. Sorry, could you go to the previous slide just before I move on to that? So, sorry, just to end on this, as Elena mentioned, we've got the important date of the UN General Assembly high-level meeting on AMR in 2024. And, as patient advocates, we could really raise our voices. We don't necessarily have to be there, but social media is a powerful tool to do that. But the stories are really going to impact that outcome. The other thing is World AMR Awareness Week, which happens every year between the 18th and 24th of November 2024. And actually this year, the the topic is educate, advocate, and act now. And as you can see, they've put a very strong emphasis on our task force and on patient stories. So yeah, next slide, please. So having said that, I'd like to introduce John Kariuki, who is an amazing advocate. He comes from Kenya. He is a veterinary surgeon by profession and works as an assistant director in the Directorate of Veterinary Services in the State Department for Livestock Development. He holds a master's degree in the area of bacterial antimicrobial resistance and also serves in the WHO Task Force of AMR Survivors. He is a member of the National Antimicrobial Resistance Stewardship Interagency Committee in Kenya. In 2020, he developed a multi-drug resistant hospital-acquired surgical site infection following an accidental right hip joint fracture. This occasioned prolonged hospitalization and a year-long recumbency. Following recuperation, he now lives without the right hip joint and with a 3-inch shortening of the right leg. So I open the floor to you, John, and I just want to thank you so much for joining us from Kenya today.
Thanks very much, Vanessa, for the good introduction. Yes, we can go to the next slide. Yes, AMR, yeah, as you know, is a phenomenon that is seen when bugs or bacteria, either viruses, parasites, or fungi, fail to respond to the effects of a drug that they were previously sensitive to. And so this calls upon us to fight against AMR. Next slide, please. Yeah, so I've just defined what AMR is, and this is a major threat to global public health. It's one of the top 10 major threats to global health. And it has an annual mortality of 2.5 million people currently, but this can go up to 10 million by the year 2050 if nothing is done. And this could take us to the prehistoric, the pre-antibiotic era, where we're going to be probably morbid of minor infections. And this will negate the advances that have been made in modern medicine, especially for major surgeries and cancer chemotherapy. Next slide, please. Yes, we need to invest heavily in research, and some of the areas that we need to invest in is in the small molecules that can help to combat AMR, especially for the AMR, the resistance that has developed against the current drugs in use. The other thing is development of bacteriophages. These are other bacteria or viruses that feed on bacteria, and therefore they are not antibiotics, and so probably you cannot get resistance against bacteriophages. And the other thing, important thing, is use of vaccines to do infection prevention control. And this way, we would minimize the need for use of antibiotics, and this would probably be able to hamper development of resistance. The other area of research is investment in strain-specific antibiotics, which will ensure that we use narrow-spectrum antibiotics instead of broad-spectrum antibiotics. Right? Next slide, please. Yes, we are vulnerable, and in the One Health approach, the environment, animals, humans, and as well as crops in agriculture, we are all vulnerable. Next slide, please. Yes, my story started on 6th of October 2020 when I had an accidental slip and fall. And this was followed by a misdiagnosis where they missed the fracture. And so radiography wasn't very clear, so we did computerized tomography. And this is when the real problem was visualized, and there was a complete fracture of the hip joint. The femur, or rather the thigh, was completely separated from its ball and away from the pelvis. Next slide, please. So I underwent surgery to try and correct it by putting in plates and screws into the hip joint. That surgical procedure was done about 3 weeks later because of misdiagnosis of that happened in the first place. Next slide, please. And I was hospitalized for 5 months. I went to 5 different hospitals. 5 orthopedic surgeons were involved or consulted, and 6 physicians as well, and over 10 healthcare workers. And during that time, I remember I had to undergo 11 pints of blood transfusion while I was in hospital because the bloodstream infection had become so severe, I had become so septic, and this was threatening function of some organs like the kidneys. And these 11 pints had to be given by donors. Next slide, please. I was released from hospital 5 months later after being hospitalized in 2 or 3 hospitals. Then I went home for recuperation, and during that time I had a full-time nurse with me, and he slept in my bedroom. And I also started undergoing physiotherapy. During this time, the only thing that was happening was a wounded dresser would come from the same hospital I had been hospitalized, and he would come twice a week. He would clean the wound using iodides and then go away. And so the wound continued oozing. Next slide, please. So in August, I decided to take action, and I did a culture and sensitivity testing with a reputable laboratory. And out of 18 antibiotics, only 1 was working. And this drug was amikacin. And what was found, the bacteria that was involved was Citrobacter frundi, together with Morganella morgani. And when I administered the drug in the first week of August, we went down from dressing the wound 4 times a day to around twice a day by the end of October. Next slide, please. And in September, we started dressing the wound only once. In October, I took another culture sensitivity testing, and this turned out negative, just in good time for me to participate in the World Antimicrobial Awareness Week of November 2021, where I shared my testimony, but I still continued to do physiotherapy all the while, and I still do physiotherapy up to today. But this occasioned a 3-inch shortening of my right leg. Next slide, please. And so I live I'm a person officially registered with the Kenya government as a person living with a disability. And of course, the impacts of this included mental torture, let me call it mental torture or mental disturbance. Of course, physically, when I used to play football, now I can only just watch and clap for the people who do things I used to do, and now I'm unable to do. Of course, it had a social impact because I could no longer mingle socially as much as I did before. The cost of hospitalizing me, the hospital bill was about $35,000. But the cost of treating myself after culture and sensitivity testing was a little less than $50. And you can count the losses in incurred because I was bedridden for almost a year, a whole year. I was bedridden. And so this impacted negatively on my socioeconomic activities. So the cost, the burden of AMR can be seen in this example of mine of loss of a daily adjusted life years. Next slide, please. Yes, those impacts, as you can see, sports, I can no longer do sports. Social, I can no longer mingle that with, although now I can because I've fairly recovered. And peculiarly, just mentioned. Next slide, please. Next slide. Yeah, so what we are saying, the global initiatives, starting with the global action plan that was developed in 2015 and spearheaded by the quadripartite. Now, the tripartite, but later became quadripartite after UNEP joined. And in 2023, the WHO Taskforce of AMR Survivors was formed. And this has contributed greatly to advocacy, where we need to take this story to the political leadership of the world, because it's a global problem. It's not a problem that is regional. And if these leaders can be made to internalize that the problem is actually global and that they are also vulnerable, then probably more resources can be allocated towards combating this silent pandemic. We are saying that this pandemic is invisible, but we are visible, and so we must use ourselves, as the chairman said, as task force members, to try and knowledge that is necessary for more energy to be geared towards combating this. And in Kenya, we have the National Action Plan, which we have developed. And I think we already renewed the phase from 2023 to 2027 with the 6 strategies, where we are going to look at governance and coordination, public awareness and education, surveillance and monitoring of the antimicrobial resistant profiles all over the country, infection prevention and control, that is use of vaccines and promotion of wash activities with water, sanitation and hygiene, as well as appropriate use of antimicrobials. And the other thing, very important, I covered it, is research and development, which we cannot do without. Next. Yes, I'm happy to be with you, and thank you very much for my short story about the very long period of time that I was hospitalized. Thank you.
Thank you so much, John. Thank you so much for sharing your story. We really, really appreciate it. I think, again, just to go back to that, this is not just, we want to try to tackle AMR on local levels. It's really, really important to do that. But it's important to understand it from a global perspective, because AMR crosses borders. So the next speaker is Rob Purdie from the USA. And he is a lifelong California resident who was diagnosed with cocci meningitis in 2012, the most severe type of valley fever. Rob relies on daily antifungals to control his disease and has used his experience to help other patients and become a leading fungal disease patient advocate. In 2023, Rob founded MyCARE, the first patient-led hand-fungal nonprofit with a goal to bring fungal patients together to share knowledge and experience and advocate for better care and increased research for their disease. Rob is becoming a sought-after speaker and key opinion leader in the fungal and AMR communities. Rob's legislative efforts have included state and national legislation and appropriations to support fungal research and awareness, and he is also a valued member of the WHO Taskforce of AMR Survivors. So welcome, Rob, and thank you so much for sharing your story. I think, Rob, we might be battling to hear your audio.
Is that better or worse?
Much better. Thank you. Perfect. Perfect. Please go ahead.
All right. So next slide, please. So unlike Vanessa and John's AMR experience, mine wasn't caused by an accident or injury. Some AMR infections are just caused by being alive. So mine was caused by, excuse me, a fungus that's just commonly inhaled in parts of the world. So all I did was take a breath. And then my symptoms began in 2012. Took me only 6 weeks to get diagnosed, which is sometimes rare when it comes to fungal infections, which often are not thought of initially. Everybody assumes bacterial or viral, so sometimes it takes a while to get to those. The good news is a lot of these environmental fungal infections don't exist in Europe, but because we live in a world where people travel quite frequently, I actually know patients with this disease who live in Europe, including one who lives in the UK. So after diagnosis, I was started on antifungals, and my symptoms started to get better. But my first hospital readmission was in October of 2012, which was 10 months after diagnosis, because the drug I was on failed. Next slide, please. So I failed a series of 3 different pills, oral medications for my disease before they put me on a combination of 2 different therapies to control my fungal infection. And that worked, but because of side effects, I failed both of those therapies. I am happy to say that for coming up on a decade, I have been well controlled, but not cured of my infection with a combination of 2 drugs. So unfortunately, my condition is incurable, but it is controllable. Next slide, please. And as John indicated, you know, the burden of disease is more than just the cost of hospitalization and the procedures. There's the socioeconomic impacts. I have a lot fewer friends than I had. I missed tons of work. The economic impact of the disease was crippling. And then since then, you know, I've battled with depression and isolation. And not only that, my spouse, my partner, has had panic attacks, which she did not have prior to my diagnosis. So the indirect costs aren't just borne by the patient, they're borne by the carers as well. Next slide. And from a patient perspective, one thing that I saw, especially with AMR, which is I kind of view it as a rare disease. My disease is rare, and so looking at it from a rare disease lens, because of the lack of knowledge, you know, we find that clinicians lack knowledge, information, and support, and patients don't have a reliable and consistent experience. They don't get good information, and they don't understand what's going on. Next slide. And part of the question that I ask people when it comes to AMR is, what level of risk are we willing to accept? You know, if your house was on fire, which one of these pieces of equipment do you want to show up? And the difference between the equipment on the left and the equipment on the right is what we as the public and as advocates are willing to allow. And so we have the ability to make the difference between these 2 options by working together and advocating. Next slide. And a lot of lessons can be learned from the AIDS epidemic in the 80s and 90s. In that epidemic, the difference was made by patients. The difference was made by those impacted. The reason it was successful was because when patients became involved, there was a lot of support. But it was started by patients. The support was quicker in coming than it has been for AMR, but it was patient-led. So next slide, please. So obviously, as part of the AMR task force, we say that AMR is invisible, but I am not. And I want to talk a little bit about how I've become visible. So, you know, like John, like Vanessa, like the other people that you'll hear speak and on the panel, you know, I was frustrated by my diagnosis. I was frustrated by the difficulty I had in getting the care I needed or getting the answers I needed. And so I decided to take action. But how did I get started? Simply by reaching out to members of my community. I reached out to my physician. I reached out to my local representative, and I said, how do I get involved? Do you know any organizations? What do you know? Help me look. And they did. And I was lucky that those people that I went to first were able to help me, and they connected me to an organization that I'm still involved with today. That's a nonprofit that works on valley fever, and through that, I was able to help them advance their platform while also creating a platform for myself to engage at the state level and the local level with legislators, leading to legislation that addressed the way testing was done, and also allocating funds for education, awareness, and research about the disease. I also was able to have impact at the national level. So after I got some experience at the state level over a couple of years, I was able to have some impact at the federal level. And there's some strength in being a patient. There's some opportunity that comes with that. So if you are a politician or a researcher or a policymaker or even an NGO that is not patient-led, you are expected to behave a certain way. Patients are given a little bit of leeway. We don't get to be rude. We shouldn't try to be rude. We don't get to be anything other than polite, but sometimes we get to bend the rules a little. I found that's extremely useful because you can ask for forgiveness, and you'll often get it if you color slightly outside the lines. Next slide. So, that's led to having some recent abilities to engage at the World AMR Congress. And part of this is being able to work with this organization and ask for a keynote panel of patients and suggesting that and making an appropriate suggestion that they found interesting. And because of that, we just had a panel of patients. Next slide. And through networking with the WHO Taskforce of AMR Survivors, they've also given me a platform. And because of that, I was able to speak to representatives at the G20 Healthcare Summit last week in Brazil. Next slide. So I have a motto and a mantra that I've stolen. And it's that the people who are crazy enough to think that can change the world are the ones who do. So I would encourage those of you who are considering getting involved in advocacy, those who are looking for opportunities to do so. On the fungal side of the equation in Europe, I've had the opportunity to work with a couple great organizations that are clinical in nature, the European Confederation of Medical Mycology, and a group called ESCMID, European Society for Clinical Microbiology and Infectious Disease. So I found a lot of support, and I think if you want to be involved and expand your footprint in AMR, that you will have the same success I have. So you can go to the next slide. And that's just a little bit about my organization, and I'll turn it back over to Vanessa. Thank you so much, Vanessa.
Thank you so much, Rob, and also to John. Thank you so much. I mean, these stories are so important. As you said, this is how we take it to the policymaking level, and this is all, what we're trying to discuss today. So thank you so much for being here with us today. So we've got a panel discussion following this with some amazing, some people also that have also got different experiences of AMR and working in the policy space. So I'd like to hand over to Alina Balestra to continue with that discussion.
Thank you very much, Vanessa, and I'm very happy to introduce our panelists. We have about 25 minutes for our panelists to discuss, and I will be joined in this virtual panel by Antonella Cardone, who is the CEO of Cancer Patients Europe, a pan-European health cancer patient association. She's a patient advocacy expert, and she wore many hats in her life, and she led previously the European Cancer Patient Coalition, and she had several leading roles in the not-profit health and employment sector in Europe. Welcome, Antonella. And Antonella will be joined by Dr. Marlene Grape, who is a Government Ambassador on Antimicrobial Resistance since March 2022. She represents Sweden and the Swedish multisectoral work to counteract AMR and its consequences in EU, as well as international fora, advocating for cooperation and reinforced global action. She has a wealth of experience on AMR, and she worked on the topic of the different roles. Dr. Grape is a licensed pharmacist and holds a PhD in medical science from Karolinska Institute. Welcome, Malin. And then we have also Diane Shudder-Smith, who is a communications professional, publicist, and also a patient advocate. She has quite a long career, and Diane has established herself as a prominent figure in the field of public relations, marketing, and crisis communication. And she's best known in this field of health advocacy for her passion on advocacy and fundraising efforts for antimicrobial resistance. And she was inspired in joining the advocacy world by her late daughter, Mallory Smith, who bravely battled a superbug. Welcome, Diane. And last but not least, our last panelist is Anna Bartakova, who is the Interim Director at Health First Europe and AMR Patient Group. Hannah has a robust background in European health affairs with a decade of experience within EU framework. She holds different positions in the Brussels bubble. And Anna, she's also been managing the first European AMR Patient Group since August 2023. So welcome to our panelists that you see all on camera. And I prepared a few questions for you, starting with Diane. Diane, it is not always easy for patients to gain access to policymakers. From your own experience as a patient advocate, how do you go from telling your personal story to engaging with policymakers and influencing policy? Was this a natural move for you, or can you tell us a little bit about it?
For me, it was a natural move because my profession is public relations and marketing. So I would not use myself as an example of an average person in terms of how they would do it. But for me, what happened was I told Mallory's story in a way that got people's attention. And I kept telling it over and over and over. And after a while, you learn how to tell the story better, which I think happens to anybody. And I had an opportunity to speak to some very high-level people early on, and then they referred me to other people. So in my case, it was just talking and talking and talking. For people who don't have any training at all, and a lot of people have really compelling stories, but they don't know how to tell them. And if I were to advocate for one thing that people walk away from this with, if they want to be a patient advocate or they want to be better at that, is to find someone who is a professional storyteller to take your story and tell it in a way that evokes emotion. And I don't want to go on and on because we don't have very long, but that's the simple key message. Learn how to tell your story in a way that isn't just about the facts, the figures, the surgeries you've had, the antibiotics that failed, but who you are as a person. What are you losing? What have you lost? I mean, Rob just did it now when he said his wife has had panic attacks. That's a perfect example of a key detail that makes his story more compelling. When he starts to talk about which antibiotics fail, personally, I gloss over. It's when the human element of storytelling comes into play that you start to really see traction and people really pay attention.
Thank you, Diane. And I'm now have a question for Malin. You represent Sweden and participate actively in EU work and in international forums, including the UN. In your experience, do policymakers listen to patients and patient organizations? What do they need from them?
Absolutely. I would say from my experience, the patient perspective is incredibly important. I mean, a desk product, a policy, an action plan is not worth very much unless you have really co-created and developed it together with the people concerned. It's not only the patients, of course, but patients are a crucial stakeholder for this. And it's not only about the development of this policy, but especially for the implementation. We have to make sure that you can really implement it, and with the support from the concerned groups. I would also say that patients could very much hook up with professionals and have even stronger voices and more impact, because together they have the different perspectives of the same challenges that you meet in the healthcare and in the treatment. I mean, first diagnostic, but also treatment of resistant infections. I would also say it's about relatability. Policymakers also do need, I mean, they are people, and they need to understand that this is really something that we are all at risk for, and that is not very well known. We all know that. And this is why I think these patient stories, but also maybe together with the professionals explaining how this is a challenge to their mission. And we have to repeat it again and again and again, because even people affected by AMR are very often not even themselves aware of it. We all know that we've been touched by cancer in one way or another, but most people don't know at all whether people were also affected by resistant infections. So I think there's really a lot to do. There's an incredibly important role. And I would also say, I mean, if we talk about patients, there are so many patients, for example, the cancer patients, that are so dependent on effective antibiotics. So it's not only the people already affected by resistant infections, but we have so many other important patient groups that could raise their voices and contribute to this. But then you have to first feel that you are aware of it and engaged by it. So I think there's really a lot to do, and especially when it comes to convincing the policymakers that we all have a role to play here. Thank you.
Thank you. And now, Antonella, a question for you. Cancer is sometimes presented as an example of successful patient advocacy, and it is a therapeutic area that receives attention from policymakers. What lessons have you learned from your experience in cancer advocacy that could be applied to antimicrobial resistance, in your view?
Thank you, Elena. As antimicrobial resistance is a pressing issue for cancer patients, and this conversation now for me is very timely as we are starting our engagement on this topic. We are currently a member of the steering committee of a project that Menarini has initiated, and we have contributed to a literature review. We will publish the data soon, but I can mention a few preliminary data which are impressive. So cancer patients are 3 times more likely to die from a fatal infection compared with a patient without cancer. Approximately 50% of death in cancer patients can be directly or indirectly linked to an infection. And AMR infections are rarely recorded as the official cause of death on death certificates. AMR infections are a threat to the progress made in innovative cancer treatments, and AMR may make some cancer treatments non-viable by 2030. And in fact, in a poll of 100 UK oncologists, 46% were worried that chemotherapy will soon become non-viable due to AMR. And the threat of AMR negatively affects patients' quality of life. We heard before from a patient experience about the social isolation that can happen independently of the infection, just because of the fear of the infection. And another argument that is very close to my heart is the cost implication of AMR. And the cost is higher than the cost of targeted antibiotic treatment. So with these numbers at CP, we cannot ignore this issue. So what are the lessons learned from previous work that we did? So first of all, we need to generate political will and influence policymakers. And we can influence policymakers through building and presenting a unified voice between patients, healthcare providers, and researchers. We need to work together. We need to secure political commitment and momentum through sustained advocacy. For instance, we could work together on a patient-led white paper with a call to action or a manifesto, and this could help raising awareness, but also we should ask for the endorsement to MEPs. And we need to raise awareness of the severity of AMR, positioning it as a health crisis that could set back many medical advances, particularly in a vulnerable population. So we need to find the right hook for policymakers and look at AMR from different angles. We also need to emphasize the patient-centered solutions as they are key driving points, for instance, in cancer advocacy. We also need to leverage public awareness and education campaigns. We also need to promote collaboration across national boundaries, and this is part of CP's essence. So to conclude here, cancer advocacy efforts in Europe have benefited from a transnational approach, and the best example here is Europe's Beating Cancer Plan. So advocates, us, should encourage the development of a new wide AMR strategy, coordinating research, funding, surveillance, and public health interventions across all member states.
Thank you very much, Antonella. And Anna, a question for you. The AMR patient group is developing AMR awareness campaigns and educational material for patient groups. As we hear from Antonella, this is really a key point. What are the skills that patients group and patient advocates need to influence policies more effectively, in your view?
Thank you. Thank you very much, Elena, for your question. Actually, the answer to that question is kind of at the very genesis of the AMR patient group that was created in 2020 after a communication campaign that we did with ECDC. And we met a lot of patient groups at that time, representing cancer patients, patients with respiratory issues and other issues, who are, of course, dealing with AMR, but it was not their primary focus. And that's where we kind of saw the gap. And we realized that maybe we could develop an entity that would actually dive into the advocacy and communication and very particular skills to have in relation to the particular topic of AMR. First of all, to profile it better, but also, as actually Antonella was saying, to see that it is an issue per se and not just an unnamed cause and complication of another pathology. So we need just to put the focus on AMR. And just to reply to your questions, I isolated four skills that we are focusing on in our work. So the first one is the one that we witnessed today. Actually, it's the patient stories. This is something that is incredibly important. This is what is the most driving, and we see it in all events. Patient stories create emotional connection with the audience, and they are actually attracting the attention from everybody, because it's really putting the emphasis on the issue. Is actually concerning everyone. It doesn't need to be somebody who is severely sick, somebody who is in the ICU. It can happen to everyone. And what we are trying to do is to help patients to deliver these stories, but also to connect with the audience, but also protect them when they are talking about these stories, because they are incredibly personal and very intimate. And we are always very grateful when patients decide to actually deliver these stories. The second skill I would say that is important is the knowledge, kind of the technical knowledge about the issue. So when you are advocating for solutions, you need to know about the whole ecosystem. You are talking about better prevention. You are talking about vaccination. You are talking about screening, medtech, but also pharma and new antibiotics, old antibiotics, research, the usage of antibiotics. And this is something that we are providing this information to our patients because this is information that is, and the situation is very fragmented all over the EU in different member states. So on national level and then on EU level, we are trying to work for harmonization, but for that you have to have the knowledge to be able to advocate and to go to policy makers with these questions. For the engagement with policymakers, you of course need to know the ecosystem and the environment. You need to know who to talk to and when. So this is also information that we are providing to our patients. We are, as you said, we are providing materials. You have to have leaflets. You have to have language communication, easy communication, depending on the audience that you are addressing. And last but not least, this is what we are doing today. It's the collaboration and networking. You need to be able to speak to different patient organizations, to healthcare workers, to other stakeholders, and to create a whole community around that issue, to be really able to put it to the forefront and to show to the policymakers that it has to be very high on the agenda. And then there is an urgency now. We have been talking about AMR for a very long time, but now it's really urgent. We need concrete solutions. And we need those solutions to be delivered to patients and to be done in a patient-centric way. Thank you.
Thank you very much, Anna. And back again to Diane. From your interactions with Congress and decision makers, Diane, how effective are patients and patients' representative at influencing policy on AMR?
I think patient stories are, excuse me, and family stories are the most effective way. And that's why they keep being brought into the conversation. But I wanted to just add a couple of things based on what the other speakers have said, which I think is really important and worth underscoring and should be included in the messaging when they go speak to policymakers. And that is the cause of death. My daughter's death was recorded on her death certificate as cystic fibrosis, but what killed her was a superbug. So that's a very, very important fact that I think will drive home the point that more people are dying and dealing with this than anybody understands. That also leads to the point, which is the Taskforce of Survivors and patient stories are critically important, and we must hear them. But we also must shine a light on people who have died, because subliminally we are conveying the message with the word survivors that this is survivable. We have to start including the messaging that people are dying from this. And until people think that they're dying from this, they're not going to understand the severity of it. Because when you see somebody like Vanessa or Rob, you think, okay, they had a hard journey, but they are still okay. And I remember when Madonna went into the ICU with a resistant bacteria, the singer that everybody knows worldwide. And I know that people in the inner circle of AMR were talking amongst themselves thinking, wow, we could really use this. But 3 days later, she was better and she was out. And so she was a survivor. But so that story didn't really help the case. So when you're talking to Congress or when you're talking to policymakers, you have to convey the urgency, not only of the problem for people who are living with it, but how many lives it's taken and how many lives it will continue to take. I think that the actual messaging and what you say is important. And what Hannah said was those 4 points: get storytellers to help you tell your story better. Make sure you know what you're talking about. I joke that Kevin Outerson, who is the executive director of CarbX, is my Henry Higgins from My Fair Lady, because I only knew my own personal story, but he infused me with language. He taught me how to speak to people. He gave me tools that would help me be a better advocate. For example, they taught me that diagnostics are a big part of the problem, and I didn't know that. And to the point about the ecosystem, yes, speakers have to be, people are going to speak publicly, have to be trained. I mean, I did media training for a living. I trained CEOs and celebrities. So I understand that. And I still myself needed to be trained because I didn't know the ecosystem. I didn't understand the complexities, the economics behind it, the different parts, whether it was climate change or poverty or war as a conflict of AMR. So once you understand the ecosystem, once you have the language you need, once you have a compelling story, and once you focus on the fact that people are dying, not just surviving, then I think you're going to move the needle in the way that we need to.
Thank you. And Antonella, back to you. As a patient advocates, we are often confronted with different policies, priorities, and limited resources. How do you address this challenge within the cancer community and ensure that AMR remains on the agenda?
This is very true, Elena. We are on a daily basis, confronted with many competing priorities and limited resources. So securing attention and funds for AMR could be difficult. The risk is that cancer and the AMR advocacy may operate in silos, limiting their combined impact. Policymakers and the public may not fully grasp the connection between AMR and cancer patient outcomes. So in this situation, in this context, potential solution could be highlight how cancer and AMR are strictly interconnected, demonstrate how AMR directly threatens cancer treatment success and patient survival, so not only quality of life, as it was said, but survival, positioning it as a core cancer advocacy issue. We also need to form strategic alliances, develop a partnership between AMR-focused organizations and other impacted patient groups to amplify the collective voice, share resources, and leverage existing advocacy platforms. We need to promote data-driven advocacy and patients at the forefront, using compelling evidence on AMR's impact on cancer patients to advocate for resource allocation and policy prioritization. We need to enhance capacity building. I mean, all these issues have already been mentioned by the other panelists, but it's very important to train patient advocates on AMR and empower them to effectively communicate the issue and advocate for change. We need to emphasize prevention, highlight how preventing AMR infections can reduce the healthcare system's burden and improve cancer patient outcomes. We need to collaborate with healthcare professionals. We need to engage oncologists and other healthcare providers to champion AMR awareness and action within cancer and other condition community.
Thank you very much, Antonella. And Malin, the UN General Assembly, as we mentioned, high-level meeting on AMR is around the corner. Are policymakers ready to make the commitments needed to address the issue of AMR? Will they also focus on community engagement and patient engagement, in your view?
I would say yes and no. Unfortunately, I mean, we if you look at the first high-level meeting in 2016 and the political declaration from that meeting and the engagement around this meeting and the preparations, I think we have made a lot of progress. It is a different landscape today. And yes, policymakers are prepared to make some of these commitments. In some areas, they're very willing to make commitments, while in other areas, really not. So if you look at the political declaration, if you compare the final text, which is now available for everyone to read, if you compare it with the zero draft, of course, you will be very disappointed. I mean, that is part of the process. This is how it works in the UN. We negotiate, we come out with something very ambitious, and then to find common ground, we need to weaken some of the language. I, however, think that if you really look at it carefully, there are many elements in there that are really important that we have. And with continued commitment and engagement, there's a lot there to build upon. And I think this is really one of the most important messages, that this is something, we're not done. this is not the end. This is just one step, and a political declaration is just a political declaration. So if you continue and increase the advocacy, continue educating more policymakers, new politicians. We have new politicians all the time. You know, we have to keep it high on the agenda, obviously. And then I think we do have a very good new starting point. It's just a declaration, but there are agreements in there that we can take forward, and that's up to, I think, very much the AMR community, and then I mean the entire AMR community, including all actors. It's about academia, obviously. It's about civil society, especially this kind of strong voices as the patients group can be, but also private sector, for example. So we have a good chance, but we really have to continue this strong advocacy work.
Thank you very much, Malin. We are heading towards the end of this panel, so I will ask each of you one final sentence. What is the one piece of advice you would give to patients and patient groups that want to become more involved in the AMR debate? And I will call your name, so it's going to be easier to contribute. Diane, you first.
I have a lot of experience as a storyteller and a professional PR marketing person. And the reason I started the Global AMR Diary was to highlight the work of all the different groups who are collecting stories in silos. They're all on one site. And Vanessa, during this Zoom, I actually reached out to Jennifer Burke from Partnership to Fight Infectious Disease, who is controlling the website, to add the AMR narrative. If you go to the Global AMR Diary, you will see all the groups that are collecting stories. You can click through to them. It's really, really important that everybody come together in one place, because everybody has their own voice. So what I can offer as your takeaway is, please come together, hopefully through the Global AMR Diary, because the World Health, the CDC, the ECDC, lots of groups are there. And if we can take all of these stories and really amplify them, then perhaps people will start to listen. The advice in PR we say is, you can't, it's hard to boil an ocean, right? It's hard to boil an ocean. But if you actually put together all the people who have done hard work for year after year to try to raise awareness, and you can put them all together in one room, you will make some noise. And we need to make some noise to put an end to this silent pandemic.
Thank you very much. And then Malin, please.
Well, I think we talk a lot about the narrative, that AMR is so technical. It's easy to distance yourself from something that sounds like, you know, it's just an acronym. So I think that is a really important thing. Don't allow people to hide behind that and distance themselves from AMR, but talk about what it really means. Contribute with more voices, with more perspectives, because we all listen to different messages and different really experiences. So, you know, don't hesitate, just continue this important work.
Fantastic. Antonella?
Well, I would add to identify the right evidence and key messages that resonate with the specific target audience you have identified. It's very important. And also I can echo what has been said before. Collaboration is key. There is a strength in numbers, and we have the power to put pressure on policymakers to bring about positive actions that can mitigate, if not eliminate, the risk of AMRs.
Wonderful. And Anna?
Yeah, well, a lot has been said already, so at the risk of repeating what my fellow panelists said, I think that the most important thing is really the communication and collaboration. So communication in the way that we have to simplify the communication about AMR to really be able to pass the message to all audiences, not only to policymakers, but also to healthcare workers, and to install a dialogue really between patients and healthcare workers, industrials, medtech, etc., and policymakers, of course, and also the connection between the different issues. We have to really put the AMR in a perspective with prevention, vaccination, screening, the antibiotic usage, and the fact that we can all come together, as it has been said, work together, combine our skills, and be able to convey the message that it is an everybody's problem, but it can also be an everybody's solution. So I think that would be the important messages of today.
Thank you very much, Anna, and I hope I didn't forget any of the panelists. And thank you to all the panelists for contributing to these discussions and the speakers before. It's been, I think, a great journey for EPF and AMR Narrative. We organized this 3 webinars on antimicrobial resistance, and it's been an incredible learning journey for me personally and for our team, for EPF, and really a great learning experience, and we hope that this is very interesting for you as well. Those 3 webinars will be available online. So currently we have available the first and the second one already, and the webinar that you're participating in will be available shortly also on our channels, but also on the AMR Narrative channel. Yes, our colleagues posted in the questions all the two webinars, and I would like to take a moment to thank the AMR Narrative, Vanessa and Francesca, for this fantastic collaboration, and all the EPF staff that contributed, Dalila, Jan, Claudia, and Laura, to these webinars. And we have currently just really 1 minute. If there are any question, or if you would like to reach out to us afterwards for comments, questions, or requests for more material, you can reach out to policy@eupatients.eu or admin@theimrnarrative.org. We will also send a follow-up email with the material for this webinar, and we really hope that this has been useful for you, and that this will be a great start or a great enhance of your advocacy journey into AMR. Thank you everyone for watching, and see you next time.